Heart transplantation. The first human to human heart transplant was performed in 1967. Since then, transplant procedures, equipment, and medications have continued to improve. Since 1983, when cyclosporin have become available, heart transplantation has become a therapeutic option for patients with end-stage heart disease. Cyclosporin is an immunosuppressant that greatly decreases the body's rejection of foreign proteins such as transplanted organs. Unfortunately, cyclosporin also decreases the body's ability to resist infections, and a satisfactory balance must be achieved between suppressing rejection and avoiding infection. When heart failure progresses, the medical treatment is no longer effective. Surgical intervention, including heart transplantation, is considered. Cardiomyopathy, ischemic heart disease, valvular disease, rejection of previously transplanted hearts, and congenital heart disease are the most common indications for transplantation. A typical candidate has severe symptoms uncontrolled by medical therapy, no other surgical options, and a prognosis of less than 12 months to live. A multidisciplinary team screens the candidate before recommending the transplantation procedure. The person's age, pulmonary status, other chronic health conditions, psychological status, family support, infections, history of other transplantations, compliance, and current health status are considered in the screening. When a donor heart becomes available, a computer generates a list of potential recipients on the basis of ABO blood group compatibility, the sizes of the donor and the potential recipient, and the geographic locations of the donor and the potential recipient. Distance is variable because postoperative function depends on the heart being implanted within 6 hours of harvest from the donor. Some patients and candidates are for more than one organ transplant: heart, lung, heart, pancreas, heart, kidney, heart, liver. Transplantation techniques. Orthotopic transplantation is the most common surgical procedure for cardiac transplantation. The recipient's heart is removed and the donor heart is implanted at the vena cava and pulmonary veins. Some surgeons still prefer to remove the recipient's heart, leaving a portion of the recipient's atria with the vena cava and pulmonary veins in place. The donor heart, which usually has been preserved in ice, is prepared for implant by cutting away a small section of atria that corresponds with the sections of the recipient's heart that were left in place. The donor heart is implanted by suturing the donor atria to the residual atria of tissue of the recipient's heart. Both techniques then connect the recipient's pulmonary artery and aorta and to those of the donor heart. Heterotopic transplantation is less commonly performed. The donor heart is placed to the right and slightly anterior to the recipient's heart. The recipient's heart is not removed. Initially, it was thought that the original heart might provide some protection for the patient in the event that the transplanted heart was rejected. Although the protective effort has not been proved, other reasons for retaining the original heart has been identified: a small donor heart or pulmonary hypertension. The transplanted heart has no nerve connections with the recipient's body, that is denervated heart, and the sympathetic and vagus nerve do not affect the transplanted heart. The resting rate of the transplanted heart is approximately 70 to 90 beats per minute, but it increases gradually if catecholamines are in the circulation. Patients must gradually increase and decrease their exercise. Example, extended warm-up and cool-down periods, because 20 to 30 minutes may be required to achieve the desired heart rate. Atropine does not increase the heart rate of these patients. Thank you.